I'll be speaking to you today about using codesign to improve services and how we used a codesign approach in this module. My name is Dr. Gavi Ansara and my pronouns are he and him. I'd like to start by acknowledging the traditional custodians of country and their enduring sovereignty of their land, waters, wisdom, and community. I bear witness to their diversity and their resilience over genocide. I honour elders past and present and emerging leaders, including Aboriginal people and elders who may be here today. The land on which I love, live and work belongs to the Boonwurrung people of the Kulin Nations. Like all of Australia, it is stolen land for which Aboriginal and Torres Strait Islander peoples and South Sea Islander peoples' sovereignty was never ceded. This is, was and always will be Aboriginal land. Now, I've heard many Aboriginal speakers say that if an acknowledgement of country doesn't make non-Aboriginal people feel at least somewhat uncomfortable, you're doing it wrong. So I'd like to remind us that what we're acknowledging is much more than just the existence of country or the names of people and nations to whom these stolen lands will always belong. I want to acknowledge that all non-Aboriginal people living on stolen Aboriginal land benefit from the ongoing impact of genocide, massacres, the theft of land of over 60,000 plus years of Aboriginal land, dehumanisation, the stolen generations, intergenerational trauma, and economic and resource deprivation. And those are just some of the impacts. So often Aboriginal people are spoken about in the past, but Aboriginal people are living and thriving here in the present and the future too. I'd like to acknowledge ongoing colonisation and systemic racism. This is a picture of my dear friend and colleague, Crystal Love, who's a sister girl from the Tiwi Islands, who's a leading speaker and community advocate, and I've used this photo with her permission to include it in my presentations. There is ongoing erasure of Aboriginal and Torres Strait Islander sister girls and brother boys. If you don't know what a sister girl or brother boy is, then please do your work and look it up. It's very important that we know and recognise and acknowledge people who are a major part of our community. I'd also like to acknowledge that when we say our community of people with trans, gender diversity and non-binary lived experience, we're actually talking about Aboriginal people, Torres Strait Islanders, South Sea Islanders, and people from other racialized and minoritized societies and cultures too. So when people say our community, often I'm not included because I'm not a white Anglo-Australian person. I'm also a non-Aboriginal person, so I'm not in either of those two groups of people. But often we're not acknowledging Aboriginal brother boys and sister girls. We're not acknowledging people such as the Bisu, who are a caste of spiritual leaders from one of 5 traditional genders in Bugis society from South Sulawesi, Indonesia, and there are Bugis people living in Australia. We're also not acknowledging Samoa and Fa'afafine, including Australian Samoa and Fa'afafine communities. Now, I'd like to thank all of the authors who contributed to this work, which included people with transgender diversity and non-binary lived experience from community, a multidisciplinary range of health professionals, and health professionals with transgender diversity and non-binary lived experience. An updated list of contributing authors who've given their permission to be named is available on the Northwestern Melbourne Primary Health Network website at nwmphn.org.au. I want to acknowledge the creative contributions to this project by Amory Oka-Johnston, who's the creative director of Thought and Found. I also wish to thank the Northwestern Melbourne Primary Health Network CEO, Dr. Chris Carter, for the funding, support, and presence that made the opening of this project possible and who's been really pivotal to this launch. I also wish to acknowledge the contributions of the 3 lead authors who coordinated at every step of this project, and that includes Dr. Ruth McNair, Dr. Cal Andrews, and Ben Caligari. I also wish to thank Northwestern Melbourne PHN staff, including project lead of the LGBTIQ suicide prevention trial, Joe Reid, and Program Support Officer in Commissioning, Xavier Walsh, as well as everyone else at NWM PHN who supported all of us to make today and this project possible. So what's special about our module? We used a co-design process instead of just a top-down process. And that means that people who were designing this module were collaborating with people with lived experience and community, because as the saying that was popularized by South African disability rights activist goes, nothing about us without us is for us. We made it interdisciplinary. So there were people from art therapy, from counseling, from medicine. There were all sorts of different people who were involved, so that we developed a really rich project that had a lot of input from people who have different ways of working and different insights and ideas. Our project was accessible. It was available free at no cost. It's also available online, which means that it allows for access for people who are living in rural and remote areas. It's also short duration. It doesn't take very long to complete, which means that it's accessible to time-poor practitioners. What else is special about our module? So it's, as I said, intersectional. It's also holistic. It addressed many different areas of people's lives. It includes non-binary people and people with other excluded forms of gender diversity who typically are not mentioned in projects of this kind. It addresses some gaps in existing training, and it's current and up to date. And we hope that there will be ongoing review and update to ensure that it stays that way. So what is co-design? Co-design is a participatory and collaborative design process. It involves key stakeholders. As I said, the nothing about us without us is for us ethos. So it involves having people with lived experience who are most going to be directly affected by the work of the project, people who have clinical experience and expertise in working with people as providers, and research evidence, because we know that not everything makes its way into research evidence right away. And we also know that people in community may have wisdom that researchers don't and that providers don't. The vantage point of a provider may also offer unique insight. So by combining these three, we really have this collaborative process from the earliest part of the development all the way to the post-launch evaluation that allows us to really be aware of all the different wisdom that different stakeholders hold. So what are the benefits of co-design? Well, it's distinct from that top-down approach of just doing a committee review after you've already built something. It really saves people a lot of work and time having to revise stuff, because a lot of times once something's built, people are not as willing to do that. And it means sometimes you can end up with something that is inflexible and not inclusive. This process was informed by all of the three components of what's known as evidence-based medicine. That is participant experience and expertise, clinical experience and expertise, and the research evidence. Co-design really differentiates tokenistic efforts at inclusion from genuine integration, genuine inclusion. So the benefits of co-design are that it involves people in decisions and content that affect their own lives, it addresses research gaps and flaws, and it identifies in-group emerging needs, experiences, and concerns. Co-design also reduces the impact of systemic oppression and privilege, reduces what's known as the empathy gap, where people who don't have a particular lived experience can underestimate the emotional harm that it can cause to be subjected to oppressive behavior. And it ensures that the actual sensibilities and needs of people with lived experiences are considered. It provides results in a more useful, accurate, and effective way, and leads to content that is more accurate and more accurately reflects the really on-the-ground needs of marginalized communities. To understand why these benefits of co-design were essential to this project, it helps to have a framework for understanding the context in which we were working. The term cisgenderism describes a form of systemic oppression that is an ism like racism or sexism, and this particular ism invalidates or marginalizes some people's understanding of their genders and bodies. This describes function rather than people's stated conscious attitudes. We know from implicit attitude tests in the field of psychology that people aren't always aware consciously of some of the biases and attitudes they have toward other people. So this goes beyond concepts of transphobia, looking at systemic oppression rather than individual attitudes or hostility. And cisgenderism is a form of systemic oppression. That is, it's built into systems and oppresses people. It causes harm, even when it's well-intentioned or unintentional. Research on cisgenderism that my colleagues Damien Riggs and Gareth Trehan conducted with me showed how cisgenderism could affect the mental health and well-being of people with trans, gender diversity, and non-binary lived experiences. This particular slide shows figure 1, a model of TGDNB mental health in Australia, illustrating how factors such as community connectedness, access to desired services, and intersectional demographics can affect the impact that cisgenderism has on people's mental health. So what is cisgenderist privilege? First, we have to understand the term privilege. The term privilege refers to unearned benefits that are given to some people and not chosen. So if you have privilege, it doesn't make you personally bad, but it does mean that you are gaining unearned benefits that other people don't have access to. That's privilege. It's based on whether, in this case, authorities and systems view people's own understanding of their gender and body as legitimate. So some people have the unearned benefit of when they say what their gender is, they're accepted. They have identity documents that match that gender. Other people have to fight for that. So those are unearned benefits that some people have. That's cisgenderist privilege. Importantly, cisgenderist privilege causes harmful disparities in healthcare. Now, for those of you who are vision impaired or blind, I'm again going to describe an image. So the image on the right is an illustration of privilege. And it depicts a person who appears to be a pale-skinned, masculine-presenting person in corporate business attire on the left, and a brown-skinned, feminine-presenting person on the right, wearing workout clothing. The person on the left has a relatively unobstructed path to the striped ribbon at the finish line at the end. But the person on the right has a ball and chain shackled to one ankle, and the right side path includes a jagged barbed wire fence, a crocodile in a pond, a broken wall with jagged rocks blocking the way, and a pit with spears jutting out. In other words, the person on the right is facing many hurdles that the person on the left is not. The caption in the image is the person on the left, the pale-skinned, masculine-appearing corporate business person, saying to the person on the right, "What's the matter? It's the same distance to the finish line." This image illustrates privilege very clearly, something that you think is not a problem because it's not a problem for you. And so that's hopefully explains what cisgenderist privilege is. Now, research has documented significantly more self-reported anxiety and depression and lower self-esteem for non-binary young adults than for binary young women and men of trans experience. Non-binary people have also been found to be less likely to seek help for anxiety, depression, suicidality, that's both suicide attempts and suicidal ideation, and mental health crisis. A community-based national sample showed that children with these lived experiences who are supported and socially affirm their gender identity have no statistically significant difference in depression from any other children. They only had minimal elevations in anxiety compared with others, and they had much lower rates of mental health symptoms than children with lived experiences who were not living as their gender. So you can see that the distress and the mental health effects are not caused by them being people with lived experiences of being trans, gender diverse, or non-binary, but they were really to do with the lack of support and lack of societal inclusion that people faced. And within Australia, we know that people with these lived experiences have poorer mental health. Research has found that key factors affecting this population's mental health are discrimination, whether or not people have access to hormones and/or surgery and/or affirming mental health support if they choose to seek that out, and whether or not people have community connectedness. So Damien Riggs, Gareth Trahan, and I found that access to services and support, as well as community connectedness, could mitigate the negative effects of discrimination and exclusion. And that's very important. That's what this project is designed to help with, is to make sure that people can access affirming support and that providers are aware of how to connect people with community. Research also showed dissatisfaction and low satisfaction with gatekeeping and existing standards of care. People were more dissatisfied with psychiatrists than they were with GPs, psychologists, or surgeons. And the main reasons for their dissatisfaction were the failure to provide information about peer support groups, so that speaks to that issue of community connectedness, and the failure to communicate with family and providing or arranging support for them if necessary. That also goes back to community connectedness, people needing to feel part of their families and their communities. So here are some excerpts from narratives that people with lived experience have shared in published research. My psychiatrist acted more as a gatekeeper to treatment rather than assisting me with any mental health issues that I had. It would have been helpful to have more support and information. Another person said, I was approved for surgery by my treating psychologist and not a, quote, psychiatrist, because I don't have a mental illness and I only suffer from gender dysphoria. Another person said, one psychiatrist was excellent and highly supportive. The second, although they became supportive, was initially hostile and confrontational. You shouldn't come out of a psych session feeling suicidal. Another person said, the concern about discussing anything other than gender dysphoria or being too honest with your mental health professional is that they may close the gate and deny the treatment you need. And that's a very common concern people have. Engaging with the psychiatrists who give you the, quote, green light to go ahead with transition is kind of just another layer of trauma that I associate with living in a transphobic society. And there you get that implication of systemic oppression, that what individual professionals do feeds into a larger system of people being denied resources and having to prove who they are to people without lived experience in many cases. Research documents little to no awareness and knowledge among some key groups of professionals who are working with our populations. According to Australian research published in 2020, so it's still current, endocrinologists, in a group of endocrinologists, only 19% felt confident providing clinical care to people in our populations. 75% felt less or not at all confident in commencing gender-affirming hormone therapy than in any other area of endocrinology. 96% had no training in trans medicine during medical school. That's quite shocking. 60% had no training in trans medicine during their endocrinology training. And significantly higher levels of confidence were found in all aspects of their care, including consultation, in those who had previously seen someone with lived experience. So in other words, once they had worked with somebody, they then felt much more comfortable. But that initial first time working with someone, many of them were encountering people for the first time. 91%, so an overwhelming majority of the endocrinologists in Australia, said that they needed and wanted more training in trans medicine. Again, part of what the module that we're working on is designed to improve. So we know what isn't helpful. What does help? Research shows that it helps to offer a range of pathways and suggested adaptations to meet people's shifting needs. That's again from Riggs, Ansara, and Trahan 2015. And a range of pathways means don't just have one way of doing things, but offer people flexibility, because there's no one size fits all when it comes to this. And attempts to do that very often end up with access barriers and health inequities. It also helps to acknowledge that the aim of any approach that we have as professionals should always be the best outcomes for people of trans, gender diversity, and non-binary lived experience as they determine the best outcomes to be, as people from our communities determine the best outcomes to be, not as providers decide without considering what people with lived experience have to say. It also helps to understand and acknowledge barriers that prevent optimal outcomes. And doing that is a really important step towards ensuring systemic changes that can meet people's needs. So I'm going to give you one example of a major systemic barrier in Australia today, using one of many possible real-life examples. So although this isn't the only example, this is a very common example, just to get you thinking about how cisgenderist oppression actually works in practice. To give you some background and context, though, for understanding how this example I'm going to share with you fits within systems of healthcare for people with our lived experiences, I'm going to briefly introduce some relevant information. So the World Professional Association for Transgender Health is an international multidisciplinary professional association considered a peak body in the field of trans health. And the vision, the intention, at least the stated intention of Wpass, which puts out Standards of Care 7, is to help people to have access to evidence-based healthcare, social services, and to promote justice and equality. Now, although that's its stated intention, it's also important to remember that there are numerous critiques of the Wpass model, and there are numerous alternatives, one of which is highly recommended by people with lived experience. And you see that model being attempted at Equinox in the Victorian area in Australia. So this is called the informed consent model. And this alternative was developed in response to both people with lived experience and practitioners increasingly viewing mental health gatekeeper roles as being a barrier to care. And there's some research suggesting that that also reduces people's satisfaction with their care and their relationships with their providers. Now, according to the informed consent model, people with these lived experiences should not have to prove that they're in clinically significant distress, that is, that they've already experienced mental health harm, in order to gain access to desired health services. Instead, they just have to possess the cognitive ability to make an informed decision about their own healthcare. And that aligns with human rights standards around the world that talk about, like the Yogyakarta principles, that talk about gender autonomy and genital autonomy. People have the right to make autonomous decisions about their own bodies if they have the ability to do that. And this means explaining their understanding of the risks, benefits, and information needed to make an informed decision about moving forward with gender-affirming medical services. So in this model, a trans person or a non-binary or gender-diverse person must attend one appointment with a counsellor or medical provider, at least one, and it's often more just for structural reasons, but at least one, to discuss the social, financial, occupational, and familial aspects and consequences of medical gender affirmation. Access to services is granted based primarily on the ability to consent to care and to acknowledge that you understand these potential consequences and have considered them for your own life. It doesn't mean people have solved all of them. It doesn't mean that they have perfect solutions. It just means that they are aware of them, and so their consent is informed. It's not based on whether or not they meet a particular criteria or a particular psychiatric diagnosis. So it's depathologizing. Again, the overall goal, the stated goal of the Wpass Standards of Care is to provide clinical guidance to health professionals so that ultimately they can help people maximize their overall health, their psychological well-being, and their sense of self-fulfillment. However, there are some parts of the Standards of Care that I think couldn't be clearer, and yet they are not how many providers practice today, particularly in Australia, and they're also little known by people who claim to be following these Wpass standards. I'm giving you this example to show you how a module like this can challenge clinician misinformation and reduce harms that misinformation causes people. So there's a section of the Standards of Care, the Wpass Standards of Care, that specifically is titled, "The Standards of Care are Flexible Clinical Guidelines." That is, it specifically says they're intended to be flexible and that individual health professionals and programs can modify them in order to meet people's needs. And part of why it says people might need to depart from these clinical guidelines and be flexible is because they may have different situations, they may lack certain resources, or specifically there may be a need for harm reduction strategies, that is to reduce harm. The idea is that they are flexible. I've had a number of providers who've contacted me and said, oh no, here's what the guidelines say, but this is not going to work for the person I'm working with. And so I just direct them to this particular section of the Wpass Standards of Care 7, which there'll be a new one coming out, supposed to be coming out soon. But it's amazing how many people claim to be following this standard, who are professionals, very experienced professionals, who know their jobs very well, who are not familiar with this particular part of the guidelines. Now, the purpose and use of the standards of care, they are not dictates. They realize that health is dependent on social and political climates, that health is promoted through public policies and legal reforms that are designed ultimately to eliminate prejudice, discrimination, and stigma. So they're not intended to be used to promote those things. They're intended to reduce them. And Wpass has advocated for a number of changes in public policy. So there's an idea that the standards of care that Wpass promote are really designed to reduce unhelpful access barriers and harms rather than to promote them. And another little known part that is, I think, couldn't be clearer, is a section that has a point titled "Psychotherapy is not an absolute requirement for hormone therapy and surgery." So they talk about, a basic screening and assessment to make sure that somebody has considered those consequences and they're able to give informed consent, but they really distinguish that from psychotherapy, because a lot of people think that you have to see a psychiatrist or do psychotherapy, and they specifically actually say no. In contrast, psychotherapy, although highly recommended, is not a requirement, not an absolute requirement for hormone therapy and surgery. When they talk about the competency of mental health professionals who are qualified to work with people, and that is particularly people to write hormone and surgery referral letters for people to medical professionals, they say that clinical training may occur within any discipline that prepares them for clinical practice. So they've got a long list. They've said psychology, psychiatry, which are the main two that are recognized in Australia today, but they also mention social work, mental health counselling, that is counsellors who have some level of mental health knowledge, which a number of counsellors in Australia who are not psychologists or psychiatrists do have extensive background in mental health, marriage and family therapists, nursing, and family medicine practitioners who have specific training in behavioural health and counselling. So you can see that there's a whole range of disciplines who are qualified to do this work as the primary mental health professionals. It is not just psychology and psychiatry. However, this is my example. As of August 2020, a popular Australian surgeon working with our populations has a patient information sheet that claims to follow the Wpass standards of care. So this professional says, for chest reconstructive surgery, I follow the Wpass standards of care criteria. But then this provider goes on to say in writing, for these to be met, I will require a referral from a qualified mental health worker, or referral from qualified mental health workers, and then goes on to specify mental health workers are either a psychiatrist or a clinical psychologist working in the field of gender dysphoria. So this person's saying, I follow the Wpass standards of care, and then is saying, I will only accept a letter for surgery from a psychiatrist or a clinical psychologist. So if we revisit the Wpass standard of care, what it actually says, it specifically says, and I've put that in bold, within any discipline, and it lists a whole range. So this professional is not actually following the Wpass standard of care. This person is creating systemic barriers and perpetuating them. And that's just one example. So when providers are not adequately trained, they don't know how to advocate for people who are interacting with professionals who might be unnecessarily exclusionary, as this particular professional has been. So just to name some of the Australian mental health professional accrediting bodies with practitioners who do have training and knowledge in this area, we've got in the field of counselling, we've got the Psychotherapy and Counselling Federation of Australia, or PACFA, we've got the ACA, the Australian Counselling Association. Also, we've got creative arts therapies. So we've got the Australian, New Zealand and Asian Creative Arts Therapies Association, ANZACARTA. And what's really important about including creative arts therapies is that for people with various kinds of disabilities, disability labels and impairments, they may need something other than talk therapy. So the average psychologist or psychiatrist may not have any training or experience in how to work with people who have limited verbal skills or who have various kinds of disabilities, whereas creative arts therapists have extensive training and experience in doing that. So by cutting them out, there's actually discrimination against people with disabilities and ableism in the way that transgender, diverse and non-binary healthcare is delivered. There's also family therapists, and that's particularly important if you're talking about communities that are not white Anglo-Australians, because in a lot of cases people have very embedded family systems, and there's not as much emphasis on the separate individual as divorced from the family, as well as a number of situations where people have much more family support because the wider community, they experience racism and other things, and it's very hard to find a psychologist or a psychiatrist from their own background. So the AFT is the Australian Association of Family Therapy. Again, family therapy was mentioned explicitly in the Wpass Standards of Care as one of the professions that can be involved in writing referral letters for hormones and surgery. There's psychotherapy, so the Packwood College of Psychotherapy and a number of other bodies, and there's also social work. The Australian Association of Social Work, or the AASW, also has professionals who were listed in the Wpass SOC7 as being eligible to write hormone and surgery referral letters. And we do need to obtain formal CPD accreditation for our module with these professional bodies, including the APS, RAMSCOP, the RACGP, and other professional bodies. I know that some of these bodies will already accept the module for CPD credits, for continuing professional development credits, but it's just worth making sure that we have official recognition. So if anyone is associated with these bodies, we'd appreciate your support. So the kind of misuse that I've described of the Wpass Standards of Care actually does cause quite a lot of harm. It reduces the flexibility that people have and denies their choice of a provider who feels like the best fit in terms of mental health professionals that they choose to engage with while they're seeking hormones and surgery. It coerces people to seek care with practitioners with whom they feel unsafe just because of their registration category. It causes unnecessary service denials or delays. It also disproportionately affects people who are from marginalized geographical, financial, cultural, and linguistic backgrounds, and really creates health disparities for people with those lived experiences. It creates an unnecessary financial burden. It also exacerbates the shortage of safe care for our populations. It perpetuates historical discrimination against clinicians who also have lived experience, because it means many of us are not registered psychologists or psychiatrists precisely because those fields have a history of particular types of discrimination against people with lived experience. And so many of the other professional bodies have higher percentages of people with lived experience in this area. It also causes or exacerbates equity issues for people with lived experience. It perpetuates ignorance and misinformation about what the clinical guidelines say. And if we go back to our definition of privilege, privilege is when you think something is not a problem because it's not a problem to you personally. So this health provider who's perpetuating cisgenderist systemic oppression may not be aware, because it's not a problem for that provider personally, that this is causing a problem for many other people. So that's an example of why this module is needed. And there are many other possible examples, but that just shows you how important it is to have this kind of co-designed module that really benefits from the wisdom of providers, of research, and of people with lived experience, as well as people whose lived experiences cut across professional and personal domains. So let's make sure to share our module widely. We invite you to complete our module, share it with people in your professional and community networks, promote the formal recognition for continuing professional development credits, and we thank you so much for attending today and for helping us to improve care. Thank you.